Like the worst day of their life is often everybody I see that day. To be able to do those things in the timely manner that we have to do them very quickly and press, but to be able to do that with an extra moment of kindness and grace was like one of the biggest motivators for me.
You'll be doing things you don't like doing in order to go on living, that is to go on doing things you don't like doing, which is stupid. Better to have a short life that is full of what you like doing than a long life spent in a miserable way.
Hey. Sorry to keep you waiting.
Oh, you're so good.
It's been a real hectic day for me.
Tell me
so I am very, very happy. Let me take my glasses off so it's not getting in my headphones way. Okay. All right. Okay. So you ready to rock and roll, Sarah?
I'm ready. Do this.
Beautiful. All right. Welcome back, you guys. Thank you very much for joining me. My name is Swadik Mayanja, but you guys can call me Q, and we are on another episode of the Everyday Hero Show, where I bring to you someone in your life or someone in my life that does good things, that does great things for us, but does not get the credit that they deserve. Today, we have someone special. I know, you guys. We talked about emergency room nursing last week, but we're doing it again this week, but with a little bit of extra sauce on top because Sarah got things. She's got a whole lot of things for us, and she's been giving back to the nursing community in ways I could only dream about doing one day. Sarah, thank you so much for coming on the show. I really do appreciate it.
I'm so happy to be here with you and all your listeners today.
Oh, goody. Listeners and viewers.
Viewers, I know.
Exactly. Exactly. You're looking good too.
Thank you.
Origin story from like, when did you decide that, where are you from? Right?
So, yes.
And how did you get into nursing?
Okay. So I started my life and journey and everything and all things in Southern Georgia. Mm-hmm. I grew up, small town, small high school. Went and we had not a lot of opportunities for professional development, career services sort of things in high school. But one thing we did have was a follow a nurse for a day program. Ooh. And I got assigned to go to our little local hospital to the ER. And I got to follow around an emergency nurse. And I had it in my brain that I wanted to be like a physical therapist, maybe a doctor. I don't know. But I was like, emergency, that sounds kind of cool. I'll go check it out. Well, that day I followed around the ER nurse, and we had agricultural trauma come in. It was like some sort of tractor trailer out in a field sort of thing. Lots of blood, lots of guts. And it was just like cruising in, and everyone was just so chill about it. And I was like, I love this so much. I think this could be amazing. So went to school, kind of wandered through studies, did the pre-med thing for a hot second, played rugby for 4 years, went to the University of Georgia, and then decided I wanted to do nursing. I did a master's entry program. So one of these, it was in 2010 that I graduated. So it was kind of early on. It was the clinical nurse leader program. That was very early on in its like role development. Graduated, started in a emergency department straight out of school. A lot of people were telling me, you have to go do 2 years on the med surg floor and get your like foundations down. And I was like, no, I don't think I need to do that. I just want the blood guts score. Yeah, just give that to me. So made my way into a community hospital ER, did that for 2 years, learned so much, and then took a travel nurse assignment to San Francisco. And I've been in the Bay Area ever since. So my whole nursing journey has been in Georgia and then out to California. And so I have like this bi-coastal perspective, I feel like. And for the last 7 years, I've been out here in the Bay, and I've just loved it so much. And that's how I've been. And I've been in the ER the whole time. So I've worked trauma, burns, stroke, cardiac, all the things. Loved every minute. And now I do a lot of focus at the bedside doing pediatric care coordination.
Okay, so we're gonna slow that down.
Slow it down.
Yeah, we're gonna.
You wanted my origin story.
Oh, I know. I asked for it, and I got it, and I'm thankful. And now we have the big picture, but now I can cut that up, and we can digest it, piece by piece. So exactly. So I want to know that experience you had the day you went and followed the nurse. That's what I want to know, because my experience as someone who already went through nursing school and then got a job as a nurse and finally followed a nurse in the ER, I was shaking to the core of who I am. And I was like, the ER, that's an insane job to do. So as a high school student to follow a nurse and think this is what I want to do, tell me about that day, that whole process and your mindset.
Well, you have to kind of think of where I was. So I'm from Southern Georgia. So we're talking like rural, slow Southern hospitality. So it wasn't like fast-paced ER kind of situation. The nurse was this guy, and he was, I don't know, he might have been in his like late 20s, early 30s at the time, but I was like 17. So I was like, he's ancient. He's so old. So he was following me around. He's like, well, this is the emergency department. That's where the ambulances come through. We're going to sit here at the nurse's station until something goes off. All right. And so we were just sitting around shooting the shit. And that's when the ambulance doors came in. I was like, as I remember it was like this dramatic doors came through and people came rushing in. And this guy had like this crazy bloody bony trauma thing from some sort of farm accident. And this guy was just like, well, guess we should put some pressure down. And like, I was just like, oh my God, this is what I want to do. Like, I want to be that person who's so relaxed in this moment that I was terrified in. And I was like, that's the person. I want to be in control. I want to be chill. I want to know the things. I want to just sip my coffee and put like pressure on it with maybe a glove on, maybe not. It was Southern Georgia, so you never know. I mean, that's what I wanted to be. So it was just like this moment of awe intermingled with kind of some, I don't know, like fixer-upper, Magnolia, Southern hospitality kind of situation.
See, that's wild. I want to know a little bit about your upbringing, because you seem super, like, I don't know, maybe it was just a calling, but you seem super open-minded to such like a different world, because like I said, it was such a different world for me. And the first time I got any experience or any like time in an ER was when I was already a nurse and knew a shit ton about nursing. So like, I can only imagine where you were coming from, and like you have to know that the process, or you know, the journey of becoming an ER nurse is a tough one to go through, but at the same time you were like, I'm about it, let's do it. I want to know the why. What pulled you in there? So
I think what really drew me to it was a couple things fundamentally. So it was that first initial experience of like, this is cool. Things happen here. Things are broken and we try to fix them. And that was amazing. I'd always been really driven to working to help people. So I was one of those people that joined all the clubs, all the volunteer groups, helping all the people all the time. And like a lot of nurses, I feel like we are intrinsic caregivers and like want to take care of our community, right? Be that family, be that our greater neighborhood, be that through our church organization or volunteer organizations or whatever they are. So that was always me. And then twofold, I was really interested in language learning. So I was really big language nerd growing up. I was like in the French club and stuff like growing up. And I went to school and started studying Spanish and Latin American studies, right? And I was like the white Southern gringa girl, like going through these classes and spending a lot of time abroad and then working with a lot of migrants in the U.S. and Georgia. So I got really interested in working with underserved minority populations, like and that kind of enveloped into healthcare and like how healthcare is delivered to these multicultural communities. And so the ER really is that place where all the cultures come together and receive treatment. Sometimes the first point of contact for healthcare for a lot of people who are new to this country is in the emergency department. So with those kind of all things combined, I would like jumped into nursing school and I was like, I want to go fix the people and fix the people that no one can talk to and try to use my language skills to try to like build bridges, you know, like and kind of not just give care, but give care in a way that makes people comfortable. Because there's one thing to like give care, but our language, even in English, medical language is so confusing and can be so intimidating. But then you're trying to translate that into another language. So using these, and I feel like even more so now that we're using a lot of screen interpreters or telephone interpreters, to be able to give that sort of personal, culturally competent care is just so fulfilling for me. And being able to do that to my patients and especially now working with pediatric patients and their families, like it's just such a gift to be able to like make their experience in the emergency department that much less stressful.
So I love that answer because that's like a perfect transition into where I want to go next, right?
Yay!
No, because you're right? So like when you think of the emergency room, you think of, all right, I'm just going to get you stable enough to transfer you somewhere else, right? Like that's totally the mindset
We're like the bus stop. You're in, you're out. That's just hitting you in the right spot, terminal, get you upstairs to the ICU fast as we can.
Exactly. But with that being said, your answer doesn't give that impression, right? Because you're talking about like the holistic care. You're talking about like, I want to mean something. Like I want to care for you in a way that I'm caring for the human being. I'm not just caring for the broken leg. I'm not just caring for the heart attack. I'm not caring for the issue. I'm caring for the person with the issue. But I mean, and I love that about you, but at the same time, but your job asks for the exact opposite. Your job is, I need to just get you stable, and then you got to go somewhere else that can talk to you in the language you can understand, treat you like the human being that you are. So I want to know, is that something that you deal with every single day, or is it like, or am I just so far away from the actual situation where you are doing that?
You're 100% correct in a lot of ways. So we're very time pressed. So we have to get things done. We have metrics. We have like door to doc time. We have door to treatment time. We have door to CT time. We have door to TPA time. We have all the door to everything time. So we're doing that quickly. But what we are doing is sometimes helping people in their moment of greatest need. Like the worst day of their life is often everybody I see that day. So to be able to do those things in the timely manner that we have to do them very quickly and press, but to be able to do that with an extra moment of kindness and grace was like one of the biggest motivators for me, because I wanted to, one, learn how to be a moment of calm in the storm for people. I think that was like always kind of a motivator. Like I always wanted to help support people, but in a way that was not just putting the Band-Aid on the hemorrhage, but also like helping the wound heal. And so I think ER really has given me that opportunity to do that and reach those patient populations that I'm super passionate about reaching. And over time, I've also developed this really big passion for other things that I never thought I'd be passionate about. So like when I started my ER career, you couldn't pay me to touch a baby. Like I did not want to touch the pediatrics. I was like, they're small, they're weird, they breathe funny, go get them somewhere else. But over time, I've really fallen in love with pediatric care. I've developed a passion a lot for mental health issues. So that like the psychiatric mental health care problem in the US is so big, right?
Yes.
But we see so much of it in the emergency department. So being able to help support people in those moments of crisis. And then also end-of-life care, which is something I never thought I'd be interested in. That's something that all nurses touch every day with every shift, helping prepare people for the end of that's inevitable for all of us, right? And I would say that working in the Bay Area has given me a really great opportunity to really get some great insight into end-of-care practices and palliative care practices that might not be as common in other areas of the country, and so has increased my interest and passion for helping families being able to support themselves and their loved ones in those moments at the end.
So I have you for a little bit, right, Sarah?
Yeah, okay, time.
Okay, good. So I am going to take us back because I really do want to push you on that issue of dealing with the wound versus dealing with the person. I know that the very few times I've been in the ER for me or a family member, if my ER nurse, my ED nurse came up to me and started talking to me like, oh my goodness, I want to understand your feelings. Where are you coming from? And like all of this stuff, I would cuss them out. Like I would hate that ER nurse.
Approach doesn't work.
So tell me how do you go about, like, I want, like, actually give me like, so yeah, go ahead.
I think like in the ER, so, on my most fulfilling day at work, I'm helping people in their worst day, right? And their moments of crisis.
Yes.
The vast majority of my shifts, though, are helping people who are not there on their worst day. They're there because they can't get into their doctor's office. They can't get in there because their insurance copay at the ER is less than at the specialist. They're there because maybe a misinformed provider referred them to the ER. And so they're there and just very confused and kind of frustrated. Like, I was supposed to be at lunch today and now I'm here because my labs were weird and I don't know why I'm here. So I think part of the approach is always not going like, how do you feel about all of this today? It's more like, okay, I like being really real with patients and talking to them on their level and just being like, okay, we're here today. Why? And what are our goals? And what are the barriers to goals? And trying to make realistic plans of action that are accessible to them. Because sometimes we in the ER are like, okay, you have this compound fracture. We're putting you in a splint. We need you to go to the orthopedic specialist and get this fancy surgery. But if I have a patient who's just arrived in the US, has no insurance, and doesn't even speak the language and doesn't know what a specialist in bones is, that isn't a realistic, accessible plan of care for them. So I like breaking it down and be like, okay, so resources. This is where we are in the community. Here's the free clinic. You need to go to the free clinic, try to get in, and make sure they get you a referral to this free orthopedist so that they can see you on the third Tuesday of the every other month that they're available, so that you, with the interpreter, that you can get those things. Because I think the problem with so much of medicine is we're trying to give prescriptions, we're trying to give treatment plans that our patients can't do. They can't achieve them. They can't afford them. They don't understand them. They don't have buy-in. So trying to figure out those motivations, not so much feelings, but like what motivates you to get better. And for a lot of patients, you have to ask them, you know, like, what gets you up in the day? And for a lot of people, it's like my cat or my dog or my neighbor down the hall or something along those lines. Or maybe they want to watch their soap opera every day at 11 or whatever those things are. You know, I think finding those motivators. So it's not so much like, tell me how you feel. It's more like, what makes you want to get better today? And what can we do to make that happen realistically today in the emergency department?
I love that. Oh my God. Sarah, I love that. What makes you want to get better today is like, that should be the motto for nursing. Like, done. You solved it. You got it.
Our whiteboard goal, but we don't have to put it on a whiteboard. Yay!
Right? I love that. What makes you want to get better today? Oh, I mean, that's definitely used somewhere.
Feel it.
But the meat behind the answer is why I like it so much. Okay, so good. So see, now that I got that, now we can move on. All right.
Cool. Okay, I'm here. I'm ready.
So talk to me about your transition from Georgia to California. And the only reason I said that is because every nurse that's ever been a nurse knows that California has the, you know, those, what's it called? Those ratios.
The promised land.
Exactly. Every nurse and their mother
land. I ain't going anywhere else.
wants to go to California. So what was that transition
sister,
like?
Uncle, brother.
Exactly.
It's amazing. So I think being a new nurse and then going to California was the best transition possible. So I was real new. I had only been working about 2 years before I went to California, the Bay Area. And so I didn't know what I didn't know. I thought it was normal to take care of, 5 to 8 ER patients at a time, like high acuity. If I didn't document on my patients for a while, it was fine. Like what I didn't get to, I didn't get to. It happened when it happened, kind of thing. When I got to California, I had these state legislated ratios. I had mandated breaks. I had to go, I didn't have a choice. I had to go away for half an hour, hour 15, depending on where I was working. It was amazing. I got to kind of, and because of the union rules, in some facilities I've worked, there's definite boundaries about what I'm able to do and what other departments are able to do. So in some places, only phlebotomy draws the blood because that's their union role. Maybe only RT does the breathing treatment. So that's their union role. So I show up to this place and they're like, you are only going to do nursing tasks. You only have 4 patients. If they're critical care, you only have 2, and you have to take breaks. And we really hope that you eat and pee throughout the shift. And I was like, what? I get to be a nurse? I don't have to be the RT, the phlebotomist, the rad tech, the transporter, the social worker, the case manager, sometimes the provider, and many other things. I don't have to do those things. I don't have to be the tech. I don't have to do all these things. So I really feel like my professional development has skyrocketed since being in the Bay Area because I have more time to be a nurse and do the nursing higher level critical care things. Now, I'm not saying there aren't days where I'm doing all those things anyways. I'm still the maid. Sometimes I'm still the RT. I'm still doing these things, but more often I'm facilitating the coordination of care than having to do all the tasks all the time. And I have more time to look back and say, what would really be the best thing for this patient and their family? And I think I get more time to have those conversations, those conversations about what motivates you. What resources can I plug you in with? Because in Georgia, I loved where I worked, but it was so busy all the time just because I was trying to get all my tasks done all the time. I wasn't always thinking about the bigger picture of what the best mechanisms of care were. And now here, because I have less patients, I can focus on each one more and often give, I think, higher quality care and also more holistic care because I can think about them as a person, not just as the patient in the room 12 that I'm working on for the next hour with the giant to-do list.
I like that. So you said because it says that you said that because you have all of that, because you're not doing all the tasks like you were in Georgia, you have your professional development has, you've had more time to develop as a professional. What are the, like, what have you gained? Like, what are the things that you think that if you were still in Georgia, you wouldn't know that now you know because you work in a place that allows you to grow in such a way?
So I think being in California has been great because I get to look more. So a lot of times in the ER and a lot of places, and I work really closely with the Emergency Nurses Association. So I work with people from all over the country hearing about their emergency nursing experiences, all the states, all the urban areas, rural areas, and all these things. And I think one of the hardest parts about being an ER nurse is that you're just so overloaded. And this is nursing in general, right? Like if you're a nurse, you're just overloaded. If you have so many patients asking and so many providers and so many other people asking so many things of you, you can barely get them done, much less with being concerned about the quality of them getting done, right? Like you're just like, I have to do all these things for Mr. Smith and Miss Johnson and Miss Vasquez and keep going. So I think when I'm able to step back, I have a max number of patients I'm taking every day. I have a max number of tasks. And if that patient is a critical care patient, I really get to focus in and really just be a critical care nurse when I have those critical patients, because then I'm really only maxed at 2. So instead of having 4 critical care patients where like I'm running from vent to vent and maybe putting them in one room with like all the curtains open just so I can like run around with all the things, because that's totally the reality for a lot of ER nurses in America. And that's what they have to do to make it work. And I'm sure they're doing the best they can with the resources they have and the situations they have. And they're like excellent nurses, right? But think of how amazing of a nurse you could be if you had the time to do the things you needed to do, not just the things they say you should do, but giving you the resources and support to make sure it gets done. And that, you know, I don't know, you're not just checking off boxes, you're also checking in with the patient, the family, making sure they really have what they need. I don't know. It's just been really great in that way. And so with that in mind, I've been able to take more time and look at their labs, look at the pathophysiology of what's going on. Like I get to look more in depth and learn more. And so to go back to your professional development question is, I feel like I've gotten a better experience, not just skimming the surface with my patients, because ER truly our nurses are often Jacks and Jills of all trades, right? Like, but know a little bit about everything, but not a lot about any one thing. I think I've been able to spend more time with my patients and like get more into their pathophys, their pharmacology, like working with our other ancillary staff to really kind of learn more about what I'm doing and embrace the greater scope of my practice rather than just running around like a chicken with my head cut off every shift.
Well, goody. Right? Goody. So I'm going to take this in a turn that I didn't expect that I was going to take this, but I have to ask it because this past summer, not like this most recent one, but the summer prior, Massachusetts actually had a ballot to get ratioed nursing. And one of the biggest arguments against it that I think got the public afraid was, oh my goodness, if we have ratioed nursing, that the ER is going to be so backed up that we aren't going to be allowed to have it. So I want you to just, being a nurse in California, you guys are the largest populated state. You have the most human beings in that one state.
We're the 5th largest economy in the world.
Which is insane, right? Which is insane. So explain to me, obviously you don't know from prior to now what the differences are, but explain to me, in your ER or in the ERs that you have been around, is that a fact? Are you guys having insane lines outside your ER and having ambulances needing to go to different hospitals because you can't take care of patients? Explain to me that process and what it means to have ratioed numbers of patients.
They've had ratios, I think, for almost 20 years now, something along those lines. I could be off with that number, but definitely over 10 and somewhere under 20. And what it really requires facilities to do is staff up. So you are matching your staffing to your census needs, right? You're not using the same staff for the same number of people and then saying you can only take care of so many. So there are big wait times in a lot of places, but that's just because we have a large population with only so many hospitals, and there's a trend in hospitals to consolidate, and they're closing campuses, and there's a lot of other factors that go into that. More people sometimes need healthcare when they don't have access to primary care. We have a huge state with a large rural area, so there's all those access issues also. But what I think really can be seen, and people can look up like wait times across the country. When I was in Georgia, there's one of the biggest trauma centers there in Atlanta. It was known for having 24-hour wait times. And in the Bay Area, if I mention that to people, they're like, what are you talking about? Because people don't wait that long. It depends on the facility, it depends on the area, it depends on where you are. You can definitely wait 4 to 6 hours or whatever, but I think you get better quality of care. You have better staffing because of these mandated ratios. And facilities are really empowered to adhere to them. They can say, like, we can validate the cost of this because our patient cares better, and the law says we have to. And generally speaking, like, if there's a lot of evidence out there that ratios show that patients have better outcomes, which costs facilities less in the long run because they're having shorter length of stay, they're having less hospital-acquired infections, they're having less injuries. There's a lot of validity into what has been going on, and we've been doing it for a really long time. I came from Georgia. We gave great care there. We had longer wait times at some of the facilities I worked at. We gave great focused care when we could, but I can honestly say that I can be a better nurse for my patients, and I think the patients benefit from that by having those ratios.
Well, that's really good. That's really good. All right. So let's talk about you a lot more, right? So now I want to talk to you about that transition you mentioned earlier on, about you going from someone who was afraid of taking care of peds and babies and infants specifically to someone that is now very excited to take care of those kind of patients, that population of patients. How did that happen? Why did that happen? And
I don't know. So the reason it happened was because I started getting really sick kids and having to take care of them. And I just didn't know what I was doing. And, you go through nursing school, you get the preparation you do, you come out, and then it's on you to like be up to date on things. And so I definitely took PALS, and I was like, okay, I can do that. And then I was like, but that equipment's really weird and I don't really know what it does. And I only get to touch it once a year when we do reviews and stuff. So then I would take like an ENPC, which is an emergency nurse course for pediatrics that ENA puts on. And that was great. But then I was like, okay, that's once every 4 years. So then what do I do with that? And so then I started doing a lot of on my own kind of education, reading, just trying to get up to date on things, like going to lectures when I could go to conferences, always about pediatrics. And then I had a couple of those pediatric patients that like change your life. Like every nurse has those patients that change their life, right? And their perspective on lots of things. But I had a few of those, and I was like, got to connect with the patient. I got to connect with their families. And I think the beauty of pediatrics is that you never have one patient. You always have at least 2 to 7, depending on how many people are with the patient, because you're taking care of the patient and their caregiver. And you're also taking care of siblings. You're taking care of grandparents. You're taking care of all the people. And again, I love that family-centered care. I love being able to make a difference. And also with kids, you can often make a difference that just seems really big. With adults, sometimes you don't. But with kids, you can really make the pain go away. You can give some stickers. You can do some bubbles. You can do some now we're up to VR goggles in my ER for pediatrics. Hey. And I'm telling you, VR goggles and some ketamine, and you're in business. It is amazing. So it's just fun. I don't know. I just started really loving it, and I loved my patients. And then I really loved the difference I could make in their care experience and for their families and everyone. And if you can make a difference in a kid, you're not just changing that one experience, you're changing their whole life trajectory and opinion on healthcare. And so if you really want to talk about being a change agent in healthcare, you really can get a really big bang for your buck working with kids and their families, because you're helping the next generation of patients be less stressed and less crazy maybe the next time they come back to you. And you can hopefully see them and their families prospering and doing really well with their health, in the future. It's just a very gratifying way to do emergency nursing.
Oh, Sarah. Oh, God. Yeah. Tongue. Yes, Sarah. Yes. I'm just saying yes, because God damn it, I've been on my high horse about this in recent past, because I do nursing news, and a lot of times I'll do these like really sad stories, but once in a blue moon I do good stories, and I just most recently did this story about this hospital that had a reunion of all these kids come by that were right, and I thought, this is what we need so much more of, because kids hate the hospital. Kids hate healthcare providers because they are afraid of us.
Well, why do adults hate the hospital? It's because they were a kid once and they got stuck with needles and no one was nice to them. Like, you got held down in some burrito thing and people coming at you. I mean, I would hate it too. I mean, let's be real.
Right. And so the fact that you're like, yes, of course you're a nurse and you want to take care of the issue that's in front of you, but you're thinking about like, how can I do this so this child will grow up to be an adult, a teenager, or a human being that has a positive outlook on healthcare and healthcare providers. That makes my heart sing so very, very much. Like, I've been on my high horse.
One sticker at a time. One sticker at a time.
Yes, Sarah. Yes. Okay, I love that. God damn it, I love that. Okay, so now let's okay, so let's go. So look, you guys, I did my duty. We talked, I think, good enough about the ER. A lot of other things that you touched upon. I had conversation with Nisa last week, so please check out that Everyday Hero show if you want to talk. Know a lot more about the ER, because we spent an hour and a half talking about that. Awesome. Now let's go into the details of Sarah. Okay. Because you do so much more, right? And I want to go to the part of you, because you just mentioned about having to change kids' minds. I want to go to the education portion of what you do, because that is a big portion of what you do. I'm just going to leave it like just open right there so you can explain to me, are you actually a nurse educator, or do you just go to these conferences and talk? Like, what is it that you do when it comes to nurse education?
So I have a business called New Thing Nurse, and it's a business platform, blog, social media thing, anyways, that I use to really try to advocate and foster change in nursing and healthcare. I do that in a bunch of different ways, and one of it is kind of an unorthodox approach to nursing education. So I do a lot of speaking events, and there's a lot of topics that I touch on. And I love my most recent thing that I'm really loving speaking on. I just spoke at the Emergency Nurses Association National Conference in Austin, Texas, like last week, about nurse mental health and how nursing impacts us as trauma nurses. And I love speaking about nurse wellness in general, burnout prevention, things like that. I also touch on workplace violence because I work with the Raise Your Hand campaign, which is a nurse-driven, led campaign organization that increases awareness of the violence we face in the workplace as nurses and healthcare staff. And then I do a lot of pediatrics and emergency nursing topics and stuff like that too. So what are we talking about? New Thing Nurse. So New Thing Nurse is an organization that goes out there, and we're trying to take all the nurses who are like burnout, crusty, salty, maybe don't know how to get to their next new thing. We identify the barrier and we figure out how to go over it. It's me and a few other really awesome people that I collaborate with. And we're trying to do it through workshops. We're trying to do it through speaking events. I do it through personal and private coaching. I do a lot of services around career services, because I find that a lot of nurses get really stuck in their career because they don't know what else is out there or how to get into a new job. Maybe they want a new specialty. Maybe they want a new role. Maybe they want to go back to school, but they haven't had to do that. They haven't had to apply in 15, 20, 30 years, or they're brand new and don't know how to do it. So I do a lot of stuff with resume prep, interview coaching, and all those kind of things. And then I do also a lot of traveling and working with nurses around the country, a lot of it through Emergency Nurses Association. I'm leaving tomorrow for a trip actually to Sweden and the Netherlands to work with emergency nurses over there. We're doing shadowing in their hospitals, and I'm going to be posting all about our adventures over there. And so opening up the people's perspective of what nursing is, because my nursing experience in the Bay Area is very different from my nursing experience in California. It's very different from your nursing experience in the Boston area. Depending on where you are, your idea of a nurse can be so different. The stereotype of what you see as a nurse, the specialty of nursing that you're thinking of. And so what I really love to do is to be able to use social media, blogging, and like online platforms to help open up the conversation about what nursing is and what we can do and what new things are out there for all of us.
Oh my God. So Sarah, do you ever stop? Like, do you ever stop? Like,
I go to bed early. I sleep a lot. I take naps. Naps are key.
All right. Okay. All right. So let's back this up because Sarah, I'm sorry to break it to you, but I'm going to have to hold on to you for just a little bit.
Okay. All right.
So let's talk. Let's talk about, you said in the beginning of that answer that you were most recently, I don't know if it was just because you were giving a lot of lectures on this or talking a lot to these conferences about this, but let's talk about nursing mental health, because another one of my nursing news stories that I have recently done is that nurses, their suicide rate is much higher than the regular population.
Yes.
And in that specific study, I know because there's not a lot of men in nursing, it said that the female suicide rate is much higher. And just anyways, nurses in general, their suicide rate is much higher. So let's deep dive on this mental illness, mental health, and just burnout in nursing.
Okay.
What's the main issue and how are we fixing it? How are you going about it?
The study you're referencing is from UC San Diego, and it came out this year. And it's a really monumental study because it basically took the data of a bunch of information from surveys that people fill out based on their occupation, and then compared certain aspects of their answers from occupation to occupation. So nurses, they took a bunch of information and they stratified it out, and we're like, okay, let's just look at the nurse answers compared to the electrical engineers and the people who work in offices and all these other careers. They did that for 1 year, and they only did it for a few states. So it's a very limited batch of data, but the data showed overwhelmingly that nurses have a much higher rate of suicide than other occupations. And it was over 50% for women are likely to commit suicide, and over 50%, women were 50% more likely to commit suicide than other occupations. And males were over 40% more likely to commit suicide, attempt suicide with than other occupations. So we're talking really high numbers, not 5%, 10%, whatever. So it's a very limited amount of data, but they've applied to expand the amount of data they're going to get access to by many folds over. So in the next year or two, we should have a lot better, larger sample size of data coming out. But this early in data and results are very concerning, right? I'm a female nurse, and I definitely don't want to be 50% higher likelihood of attempting suicide. Okay, so that's the first piece of that. So the second piece is we all are nurses. We all know we're stressed. We're overworked. We're being asked to do more and more with less and less. Are we getting the support we need to process what we're seeing every day? Are we getting the support we need to do the things we're supposed to be doing every day? What is the nature of our work? Is our work just filing papers? Well, for some nurses, it might be. For the vast majority of us working bedside, we're interacting with people, again, sometimes during the worst times of their life, or people who've been seeing horrible things for a really long time. And so we're absorbing all of that. We're supposed to be emotional support for others, but what's the emotional support for us? So we are getting increased stress. We're having horrible compassion fatigue. We're facing burnout. In the ER alone, they have one of the highest rates of turnover in any nursing specialty. And there was a study that came out a couple years ago that said, on average, an ER will turn over its entire nursing staff every 5 years. Yeah, that's the face. That's the face you should make. That's the face you should make. We are hemorrhaging ER nurses. And in other units, in other specialties, it's similar. AACN has all this data about burnout in critical care nurses, progressive care nurses, telemetry nurses, med-surg nurses. We're all facing really high rates of burnout. And I think we all kind of know why. And they're just now starting to research it. So we now are getting evidence-based results, our research-founded results of astronomical rates of PTSD, of stress, of fatigue, of burnout in nurses across the board, right? Okay. So this is the reality of where we are in America. We have a very high pressurized healthcare system helping people who don't have access to the things they need. They're very sick. We're giving our heart, mind, body to these things. We're physically suffering. How many nurses? I always start a presentation with, imagine your coworkers. Now imagine coworkers and say who there is complaining about backache, headache, shoulder pain, couldn't sleep last night, I'm tired, I'm going to the gym this week, or I'm on a crazy fad diet that's supposed to help me decrease my weight because I'm just stress eating all the time. Okay, we're thinking about everybody that we work with, right? And the problem is, the healthcare culture changes slowly. Healthcare systems are going to change slowly. There are now trends to look into how we can help our nurses from a facility standpoint. But what we as individual nurses have to do is realize what we need to do is take care of ourselves, and that we can't take care of others if we don't take care of ourselves. There's overwhelming issues with depression, anxiety, panic disorder, and suicide in nursing, and it's real. And one of the problems is we're not talking about it. We love to complain about what's wrong with our jobs, but we don't like to talk about how we're feeling about things. And there's a huge stigma around, can you be a successful nurse, a good nurse, if you have mental health challenges or if you're struggling with your mental health? I have a long history, and I'm really open about it with depression and anxiety. I've been really low at times. I'm on medications every day for antidepressants. I have rescue medicine that I take for panic attacks, and I see a therapist. And that, together with a lot of other things, has helped me get to where I can still be an ER nurse almost 10 years in. It'll be like 9 years next year. And I can successfully say that I've been through some of the hardest moments of my life in my career with the support of many multi-pronged approaches of treatment. Evidence shows that people who commit to self-care will have better outcomes with their mental health. People who commit to exercising, to eating well, to sleeping well will have better mental health outcomes. But our jobs aren't setting us up for success in the things we need to do. So we have to recognize what we need to do and move forward with that. And what I really like to focus on in my efforts with New Thing Nurse, in the talks I give and the workshops I give, is advocating for an open conversation. So I have a new lecture I just started called Nurse Mental Health. Let's talk about it. And the reason we need to talk about it is, one, we need to talk about it to decrease the stigma, which is a huge conversation around mental health in mental health care, medicine, and everything anyways. But specifically to nursing, we need to end the stigma that you can't be a good nurse, or you can't be a ER nurse, so you can't be a critical care nurse if you're depressed or if you're anxious or whatever. Like, we're very cowboy about things. If you talk about that you're sad or scared or nervous, like, you're looked down as weak. And we have to take that away. We have to stop that right now. We also have to start being supportive and checking in with each other, because we are losing our coworkers to suicide. We are losing them to substance abuse. We are losing them to other jobs that might be easier or less stressful, because they are not getting the psychosocial support they need to stay in the ER, to stay in critical care, to stay in med-surg, wherever it may be. And we also aren't reporting it data-wise. So when they're trying to do research now on mental health and nursing, but they will send out thousands of surveys, often these researchers will, and they'll only get like 100 back, because we are underreporting. We aren't comfortable even filling out an anonymous survey to tell people about it. And so by us not talking about it, we're like perpetuating the cycle of underreporting, no data. The facility's not going to change anything if they don't have data. We don't have evidence-based practices. We aren't studying it. And we're also limiting ourselves in how successful we can be, because we're not talking about it and being supportive of each other. So what I really want to do is, like, one, just tell people it's okay to talk about it. Like, I'm a successful, good ER nurse. I'm a really great ER nurse. Some days not so much, but some days I'm a great ER nurse, and I'm on antidepressants, and I have a therapist, and I've been sad, and I will be sad again. It's not like it ends just because I'm on drugs. I will continue to take them and have to go up and down on my meds, and it just depends. And I think the other piece is that we have to recognize what we have to check in with, what we need, and we have to empower ourselves to tell people what we need. Like, hey, I need to talk about it. Hey, I need to take this day off. Hey, I need help over here because I'm sad and starting to freak out at the bedside. We need to be able to take those moments and have those open conversations and not fear societal repercussions of looking at us as weak or inferior or incapable of doing our job.
Wow. Just wow. Look, listen. I have so much to say about this, just because, look, Look, so the way you're talking about it is literally, and I hate when people say things like this, but it really is like a paradigm shift. It's like literally like you're trying to change the culture. You're not trying to change a task. You're not trying to change like, oh, this is something extra you can do on your day off. No, you're trying to change the culture. And if you just switch, I mean, listen, y'all, I mean this in the most respectful way possible. But if you just switched I'm talking about professional, like nurses as a profession, to toxic masculinity, it's crazy how much of that is like, it's similar, because I feel like it's so crazy to me. It's crazy to me to say that, but yes, at work, sometimes I feel like people are going to think of me less if I say I need help with my med pass today. I feel like people are going to judge me if I say that patient that had a fall, it wasn't my patient. I couldn't control whether they fell or not, but it made me feel some type of way, and I need to go sit down and either vent or cry it out. It's so much, Sarah. It's so much. But you're right. The culture needs to change. Because as much as us nurses like to complain about it, we are not trying to fix it. Like there's not, like you never hear that conversation about like, okay, so how can we fix this issue? No, we just bitch and moan all day, because that's what we do at the nursing station. All right. So, okay.
Well, I will say that just on an optimistic note, there are nurses working on this, and there are people trying to research it and advocate for change. And there are people, I think, even in every unit who are starting these conversations and trying to figure it out. There's things, even institution-wise, that are coming out that show people are aware of our needs. There's something called a code lavender, which you can call, which is almost like a code gray. If like someone's feeling like I'm feeling I can't emotionally handle my job right now, there's some facilities that have an actual code response team that show up to emotionally support the nurse. Like, it is amazing. And take them out of bedside staffing for a little bit and try to help them out. There's something called the medical pause, which was developed by a critical care nurse in, I want to say, Virginia, who after a patient passes away and there's the code effort and everything has been stopped, in the moment at the bedside, all the staff that want to participate can take a moment of silence to honor what has just happened, to honor the person that just passed away, and process what they just went through. And there's also critical stress incident debriefing. And that is where you get together like 48 hours after the event, a stressful event, traumatic event, and kind of go through and like a group setting, kind of what happened, how you felt about, and all these things. So these are evidence-based practices that help show that it's helping us process and be more successful, healthier people, healthcare staff in the future. So there are things happening, but they are slow. But if you think that those are things that would help you at your facility, go and research them. Find the studies that are out there, find the evidence, and take them to your leadership and advocate to try these things, because that's part of us being bedside nurses and advocates for change. We have to take this on, because if we're waiting for the facility or society or the patients to take this on, we're going to be waiting until we're old and gray. And I already started dyeing my hair, so we got to like get on work to try to like shift all this now, so that it's not when we're old and too old and damaged to be able to take advantage of it.
And I respect that. And I love that. But again, I really want the actual actionable, like, things, right?
Yes.
So
yes.
I need you to tell me, has any of it actually worked in your practice? Give me the honest answer. Don't BS me, Sarah. I want the honest truth. Have you done any of those things, and has it actually helped you?
Yes. So my focus with pediatrics, one of the most traumatic things I have found that I see in the ER is pediatric death. And so that is something that is devastating. Like, if you go through that and you're there, part of the code response, you are an amazing being and you are strong beyond measure. If you can get up the next day, drive home that day, I mean, it is one of the most devastating, emotionally devastating things that can happen to you. So what I have done, the debriefing process, and it has helped me infinitely in those moments to get together with my team and be able to talk, cry, discuss what we did, how we felt. It's not a moment to do case review. We're not going through and be like, we should have done this and we should have done that, and maybe this would have changed the outcome. No, it's like, I felt this in this moment and I feel this now. And I need to, and being able to identify with my community and be like, I'm not the only one struggling has been infinitely helpful in those moments. I also take a lot of time to now advocate for the time I need. If I feel that I'm getting buried under a very stressful assignment, I am very vocal in communicating with my leadership. So my charge nurse, my flow nurses and things like that, to be like, listen, this is really hard. I'm going to need some help. I make sure I take my breaks, because if I don't take my breaks, I don't get that time to process things. If I'm having a bad day, I'll take a walk outside if I can. I work day shifts, so I have, the light out and I can do those things. I make sure I eat. They sound like little things, but just being able to pee is kind of a luxury. Like when I got to California, I was like, I get to sit down and eat food and take a moment in the bathroom. Like I would work 12 and a half hours in Georgia and I would shove a power bar in my mouth and keep going. And I was 25, so I could do that. But when I got to California, I really got to actually take care of myself so I could take care of other people. And my mental health has been so much better because of it. I went through a period where I was really burnt out. I wasn't sleeping. I had insomnia. I was on sleep aids. I was having super horrible anxiety and really bad depression. And by adjusting my personal practice with a lot of these aspects and other things, in addition to therapy and medications, ultimately, and switching shifts. So I got off night shift and went to day shift because I personally always struggled sleeping during the day. But even admitting that to myself, that I can't hang on nights, that was how I looked at it. I'm weak. I cannot be a good nurse because I can't hang at night because I couldn't sleep in the day. And that was just how my body was. But when I finally even got to the point where I forgave myself for wanting to switch shifts, that's where I was in my mental confusion. I was so much better. I was sleeping at night. I was rested, and just those basic things of being able to eat, sleep, pee, you're a different person. And then once you can go beyond that and really do the things you need to do, it can be a life-changing experience and definitely a practice-changing experience.
Congratulations, Sarah.
Yes.
No. But I really do mean that, at a personal level, congratulations, because that is huge, right? That is huge.
It was big, and it took years, and it's still an ongoing process. And that's what I like to remind people is it's not like I'm here and will always be here. It's an up and down forever,
So just to push on that just a little bit, where have you found, and it's nice, I don't want to say it's easier, but it is nice that there is the policy that you have the ratios where you're at. But where did you find the most pushback when you were trying to develop these everyday things for yourself to have better health? Where did you get the most pushback, and what did you do to overcome that?
So I think a lot of it's around the culture of nursing, even being hey, I need to take my break, to the break nurse can often be what do you mean you need to take your break? I'll tell you when you need to take your break. You get a lot of that kind of pushback sometimes, not always, but sometimes. And I think just being more proactive about my communication style has been really helpful. So saying, hey, if I come in at 7, hey, I would really love to take my first 15 at 10. If you can put me down on your list, that would be great. And I usually take my lunch at 1. And then if I could step away for 5 or 10 minutes at 5, that would be great. And just being proactive in that way. Because the most pushback I get is that when you ask for something in the moment you need it, and it's something I need to go take a break, it's often looked on as a sign of weakness. You want to step away because you're a quitter is kind of the general feedback you get. But nurses are practical. They're logical people. And so I think sometimes what we need to verbalize in our communication with our colleagues is sometimes a care plan. What I need is my care plan for the day, and I need you as my break nurse to know it. So my care plan will be approximately at this time I need to go take a break, and then at this time I need to take a lunch, and then I also will need a 5 or 10 minute situation in the afternoon. And once they go, okay, and then they get used to that, and I advocate for that every shift, people don't give me any pushback anymore because they're just Sarah's that nurse that likes to take her breaks. And by doing that, I like to think that hopefully I can empower other people to also say, hey, maybe it's okay for me to take my breaks. Because sometimes you just need to find someone else to know that you're not alone, that I also would like to eat my lunch. I would also like to use the bathroom. That would be amazing. And not to feel as if you are different. Because if you feel like you're different, you're not going to ask for those things. And I think that can sometimes be the biggest catalyst for change, is just having more than one person speaking up.
Okay. So last question on this, but I think it's super important, and that's why I keep pushing. But what advice do you have for those nurses that don't have break nurses, that aren't in California? Like when you do go on your tour, your talks, what do you tell those nurses? Because literally those words coming out of your mouth was the first time I've ever heard of a break nurse. So what advice do you give to everybody else?
Okay. So first, medicine is evidence-based. We go with the numbers. So you need to pull up the studies that are most applicable to your community and your setting. So if you're in the emergency room, it's most helpful to pull emergency nurse
studies,
burnout studies, right? Or break studies or fatigue studies. And you have to figure out what do you want? And then what is the thing that fixes? And then what are those data points that might be being collected? Because sometimes you might be like, I need more breaks, but I don't know how to advocate for that. And then I'm like, okay, go find a study. And they're like, well, what do I look up in the study? Like, what do I look up and where do I look up? So I think having resources of where to go to find studies, what are the words and terms that people are using? Because in research terms are very different sometimes than what we would normally talk about. Also bringing that data to the right leadership. So, your CNO might not be the person you want to hear this because they might not actually be the people who can affect change. You want to start with people who are really going to have buy-in. Charge nurses are great people to start with. Unit-based counsel. Nurse managers, nurse educators. Educators love data. They love research. And then move up to your director and higher up levels. And often correlate it with how the things that healthcare facilities love is how patient outcomes are going to improve and how they can save money. And if you can find the data and that ties in with breaks make patient outcomes better, which ultimately save you money, you have a conversation in a language now that they're really going to listen to, right? It's great to hopefully go to leadership and say, the wellness of our nurses is suffering and we think we need breaks because it would really improve staff satisfaction. But let's be honest, that's not very compelling. But if you can go up to them and say, you're going to save money annually, X amount, because patient outcomes are going to be better. Nurse retention is going to be better. How much you spend on hiring and training new people is going to be better. Workers' comp cases. So if your occupational injury rate is going to go down because you have better staffing and better breaks, those are the things that they're going to listen to. And so finding the right people and the right talking points is the key piece to really affecting change in your facility, I think. Because you don't even need legislated ratios. This is just common dollars and cents, which they're really into.
Yeah, dollars and cents is what, management and above. If they have that name, management, and there's someone above that name, that's all they care about. No, I'm lying. It's not all they care about. It's not all they care about, all right? Because patient safety, everyone cares about. But it's a lot of what they care about. So if you have research, and you're right, nurses are logical people. And so it makes sense to us as well. But it would, okay, all right. Let's leave that there because it is some legitimate, fantastic advice, and I love that. And I love that you allowed me to push back on you. So let's talk a little bit about before we move on from this education thing that you do. Is there a topic that is that something that you've been talking about recently or that you love talking about in general that is underrated or is not talked about as much? Is there something that is there a thing? Is there a topic?
So I think one of the most underrated but most fun things about nursing is global nursing. So what does nursing look like around the world? And what can we learn from each other? And how you can travel around the world and have so much in common just by being a nurse with so many people. Because if you look at all the people around the world, how many people identify as being a nurse? What is a nurse? What does that role mean? Where do they work? What does it look like in their facility? Are they in the home setting? Are they in a clinic setting? Are they in a shaman hut? Are they in some sort of, religious facility? I think that can be so interesting. And then going to those places and learning from each other, or even just having conversations. I think one of the greatest things about professional organizations is conferences where a bunch of people from all over the country of the United States even get together and talk about what works well in my ER might not be happening in your ER, but might help you, or what you're doing in your ER on the East Coast might really help my West Coast ER. And being able to adopt and collaborate different practices to help elevate the level of care your patients get in your department, whatever that department is. So, for example, the Emergency Nurses Association, which is like my heart, like that's my professional organization, started a program called the Cultural Exchange Program last year. And so we took a trip. It was almost 40-something ER nurses from all over the United States went to Norway, and they went to Poland. And we got to shadow and go do education opportunities, learning about the healthcare system, the emergency system, and the nursing education system about those two countries. And we saw all kinds of things that really were treated differently, that were approached differently, that I felt we could adopt back here in the US. We're repeating that trip, and I'm leaving for it tomorrow, and then we're going to the Netherlands and Sweden. And I think every time you can go somewhere, like every time I take a vacation with my husband, my family, or wherever, if there's a hospital nearby, I'm pretty likely to be like, hey guys, do you guys want to go like tour the ER? Like that would be really fun, right? And bless my husband, he will go places with me, and he'll be like, sure, we can go look at the emergency department. Or I'll be like, there's a fire station. Let's go look at the fire station. And there he's like, okay, sounds great. I'll take photos. It'll be good. But I think just being able to see their equipment, seeing how they approach things, what they wear, what they eat, what they're talking about, who they're treating, you can learn so much just by visiting places. You can learn so much about reading online. So reading blogs from nurses abroad. You can read about on social media, just following different healthcare providers on their social media accounts and seeing like what they're talking about, what's trending, what's different, who they are and who they're treating. And then also especially for me in the emergency department, my patients come from, and really anywhere in healthcare, we get patients from all over the world, right? It's not like we only treat Americans from our little neighborhood. We treat people from all over the world. And so being able to say like, if I have a Norwegian patient, yeah, I've been to Oslo and I ate salmon 25 different ways. They're like, oh, you've been to my country. That's amazing. And that gets me a little bit extra in with them, and sometimes can make the difference in their care experience.
I like that. I like that a lot. Yeah. And I have to say this. And again, I'm trying to be as respectful as possible. Right. But coming from someone that has come from rural Georgia, the things that you're saying just makes me so happy. Right. It makes me so happy.
There's good people everywhere.
Of course.
It's sometimes we don't get represented very well.
And you guys definitely don't, because up north, when you're in the East Coast, especially where, in New England, what pop culture says and like what we know as from like the South is conventional, conservative, traditional, which does not translate to worldwide. I want to know what everyone else is doing. So it's really nice to hear. And yes, just yes, right? Yes. So that's good. It's good things all around. Good things all around. Before we wrap this up, okay, I want to switch back to the actual. So we've been talking about nursing and how nurses can be better. I want to switch back into like the actual patient care, right?
Yes. That's why we have a job, right? We're there to take care of the patient.
That's what we do.
Yes.
But I want to know, how do you? It's just, for me, it's really hard for me to like, and I don't know how to say this. It's really hard to care the same amount for every single patient, right? So what are you doing to make sure that your biases or your inclinations or whatever is not impeding on the amount of like care? Maybe you can't give your heart to every patient, but you can definitely give the care to every patient. So what are you doing specifically to care for every patient at least equally, like at the base where you're giving them as best care as you can?
So I did grow up in rural South Georgia, and so it's a place that really focuses on stereotypes in a lot of ways. And I will say culturally that happens, and that happens everywhere.
Literally everywhere.
And I think once you're in healthcare for any period of time or any industry, you start having your own stereotypes and assumptions about different kinds of people based on how they act, where they're from, what you know about them, how they talk, their accent or whatnot. So what I really have been focusing on the last few years is really trying, every time I walk into a patient interaction, is not having those stereotypes, not making assumptions, and just trying to walk in and find positive things to focus on with those interactions. And that can be hard because people are insulting, people are frustrated, people are sometimes violent. But setting up enough boundary just to be like, I don't know about these people. I don't know what's going on with them, but today they're here for a reason. So again, establishing what can we do today and what makes you want to get better today. And sometimes focusing on those things. And the common thing that often we have in common is that we want to help them feel better in some way. Now, not everyone wants to feel better, and not every patient.
Do you believe that?
I do. I have to, because it's in the ER, it's hard to be like, everyone wants to get better all the time. No, let's be real. Like, the reality is people are coming in and they don't want to get better, but maybe what I can do today is help them, remind them that they may have something to get better for, and trying to find those things. So I try to find the positive things. So if people have a cat on their sweatshirt, I'll try to ask them about animals. If people are coming in with a certain sports cap, I might try to ask them about their sports team. People always love something. And so trying to find that positive thing and like identifying and coming together on those things, I think helps keep me positive and helps at least motivate me to at least have something to talk about that might be a good thing for both of us. And I also try to remember that there's something to learn every day. So every shift I go in, especially with emergency medicine, with all medicine, with all nursing, it changes every day. The evidence changes every day, and trying to find those things that might interest me more. If I have patients coming in and there's something new or different, maybe about them, talking to them about it. Maybe I see a new med on their med list. We have patients on all kinds of crazy medicines now, being like, hey, what's this for? Tell me about it. And trying to get, if I can learn one thing from each patient, no matter how little it is, my day is better. Like I've changed and evolved as a human. And so if I can help my people, if I can learn from them and they can learn from me and we can both get something out of it, that helps me stay positive. But I'm telling you, I have bad days. Everyone has bad days. And there's days where I'm just calling the police because these people are not acting right and they're insulting me. But setting those boundaries and maintaining my own safety and self-awareness and advocating for myself, it's all part of being a productive nurse, I think, today in today's environment.
Yeah. And that's that's exactly what I think, and I think most nurses do that just by intuition, that's just their intuition, because you're right, everyone ends up, all you need is that one connection, and then it's like, oh my goodness, that's my favorite patient, right? Because we both like the Patriots, or because we both went to vacation to
really. See, we were doing so good too. We were doing so good.
But no, you're right. As long as you find that all you need is one connection, and then bing, bang, boom, everything else is we're the same human. I know you, you know me. Let's get through this together. So totally. I love, that's all you need is literally that one connection. So Sarah, I've taken you all day, and I loved where this conversation ended up going, because we need to do this again. Please. And the next time we do have a conversation, I want to focus hardcore on that global piece, because it was literally when you were talking, I had a million questions wash upon me that I wanted.
Let's do it. I wanted
to talk about. So when you return from Sweden or wherever, you please just shoot me a message. We'll reconnect. But
we'll get it done.
I call you an everyday hero, right? I call you an everyday hero.
That's so sweet.
And that's the name of the show. And I only bring people on that I feel I could bring positive energy to more people, and they just need to share that. So I always ask for advice, right? Advice. Mm-hmm. Sarah, give advice to nurses, new nurses. And we focused hardcore on the mental illness and the mental health of nurses. So the question is preventing burnout. Your ED nurses specifically, you can focus on that, or just nurses at large. What is your best advice you can give to nurses today in 2019 about preventing burnout?
So I think the biggest thing you do is to talk about it, to talk about what's going on every day. We do have limitations of what we can talk about. We have HIPAA, right? But
Yes.
I think having your community and being able to talk to those people, I don't care who it is, if it's a coworker, if it's a friend, if it's your family, if it's your spouse, if it's your dog, if it's your plants, you got to be able to go and talk it out with someone. I love my therapist, and I think she's one of the greatest things I've ever invested in, but that's not for everyone. But having someone to go talk about it, because if you just keep it in and try to process it, it's just going to break you down. And I think also remembering that you're not alone. There is a whole community out there in real life and online, which is also in real life now. So you can always reach out. So my website is newthingnurse.com. And I have a blog that we talk about all kinds of things and also interview really cool people doing really cool things. I would love to interview you, Q, for the blog. Like that would be amazing. And, but on social media, you can reach out anytime. Like there's people with huge followings that are having great conversations with people from all over the world. And so if you're ever in that moment where you're feeling by yourself, go online, reach out. I am on Instagram and Facebook at New Thing Nurse, NEWTHING nurse. And I would love to hear from you. There's never a moment where you should feel by yourself. And when you're feeling low or sad or mad, and you have to know it's okay to feel that way. And so having someone to talk about it and just making sure that we're talking about it together as a nursing community, ultimately things will change and we will be stronger because of it.
Before I ask you my final question, I want to just push a little bit more on that, because
yes.
You are super open about the fact that you have a therapist, that you're on medication, that you struggle with depression.
Yeah.
Sarah, that's not normal. That is literally the exact opposite of normal, right?
Yes.
So how did you get there? Have you always been there? And
no.
Yeah, like
it took so long to recognize that I grew up in a family where we talked about our feelings kind of, but we also probably had a lot of mechanisms that vacillated between super healthy way to process things and not super healthy way to communicate and process about things, like most families, right? We have our ups and downs. And then I became an adult and moved out on my own and went through school and like nursing school, like that's a whole different conversation, but nursing school is one of the most stressful, horrible things you can go through as a human. Like it tears you down. You're doing none of the things you need to do to process things right. You're just trying to survive. I literally did not sleep, lived off protein bars, caffeine and alcohol, and pushed through and did the things I needed to do just to get to the NCLEX and the best NCLEX. So with new nurses, you come out like the shell of a human. And then you start a new nursing job, which is like the next most horrible, stressful things you could ever do is become a nurse, like go through a residency program, no residency program, internship, whatever it is. So then by the time you're an actual nurse entrusted with the health and wellness of other humans, you are like dust in the wind. You're like, there's nothing left of your coping mechanisms. So I think, I forget what the question was, but anyways, being a new nurse, like you have to realize that the system is not healthy. We need to change the system. That is going to take a really long time. And so we have to come together and like be advocates for change and advocates for ourselves. And so it took a really long time for me to realize like how unhealthy my mental health situation was. So I came out of nursing school. I was not handling things well. I worked nights. I couldn't sleep during the day. I did that for years before I realized like I really needed to stop taking chemical sleep aids and probably just sleep at night like my body needed to do. I got to the point where I was crying all the time, screaming at people, like not responding normally to like my friends and family and loved ones, even outside of work. And at work, I was getting to the point where I was like hyperventilating, having chest pain. I was having panic attacks, like effectively panic attacks. And I was still like muscling through it, but not in any good way. I was also stress eating cookies all the time. Like I love sugar. That is my thing. There was nothing good coming out of this. And so it got to the point where other people were like, hey, are you okay? Which is amazing that I had people checking in on me like that. And then I finally made an appointment with a therapist just because like people were like, you have to do something. I was like, I'm not taking medication because there's nothing wrong with me. I'm a normally abnormal person. And ultimately my therapist helped talk me into realizing that maybe things weren't okay. Maybe I needed to make changes. And so we started little bit by little bit, baby step by baby step. And ultimately I was getting to this point where I was going to appointments and people were like, oh, can you hang out on Thursday? And I'm like, no, I have an appointment. And they're like, well, what are you doing? And I was like, my hair, the doctor. You know, there was only so many excuses I could make. And I was like, this is crazy. I should just start telling people. So I started with like close friends, and I was like, Thursday I'm going to the therapist and I'm talking to them. And they were like, oh, okay, that's cool. Like some people were just like, that's fine. I have a therapist too. And I was like, you a therapist? Why didn't you tell me I have a therapist? And they're like, why do you think I have an appointment every other Friday? Like that's just where I go. I was like, I thought that was a nutritionist. There's just some reason, like I had this big thing built up in my mind. And then once I started talking to them, I started talking to my family. I started talking to coworkers, just like a little bit on and on. It just opened up all these conversations that people were going, oh, me too. And then I was like, oh, I'm not by myself. And there were so many other people like, oh yeah, I get sad. I cry. I talk to people. I'm on antidepressants. I'm on blah, blah, blah. And by the time I was on my antidepressants, which I need to be healthy, it's not what everyone needs, but I need these to be well. I just was like, I try to make it a point now to talk about it, because I feel like when we're hiding, I was so much less well when I was keeping it all in and holding it all in. And now when I talk about it, I'm better. So for me, it's just better. And then I find that it's usually a positive effect on other people, even though often they're like, you're weird. Why would you ever admit that? But then they usually have questions. And so I like being able to educate people in that way. But it took a really long time. I'm talking like a decade, like forever. So that's what I always tell people. It's like, it's a work in progress, and I'm a work in progress. Like I have bad times. I have good times. I have, I'm like anybody. Bad days at work are bad. Usually the few days after that are bad, but now I don't get in bed and cry with Netflix on for 3 days. I might only do it for 6 hours, which is manageable. And that's okay.
Yeah, no, it's most definitely okay. Two things that I picked up of two very important things. Number one, that was the greatest explanation of the mental status of a person going through nursing school and becoming a nurse. That's literally that's exactly how every nurse's experience is, from starting nursing school all the way to becoming a nurse. That's number one. And number two, you've touched upon this in many different ways throughout this entire interview, but I think it is so important, and just like at large, just knowing that you aren't the only one that feels a certain way, that needs certain things, that whatever the situation is, knowing that you're not the only one that feels, needs, wants, desires these things is, I think it's almost, it just allows you to say, okay, so now we can move forward from, you acknowledge it as a thing, and it's not just I'm a crazy alien. No, I'm a human being, and other human beings feel these things.
And putting words to it. Words are powerful. Like we have to have a language to be able to talk about things. And so sometimes being like, I had to have a language of words to put to my feelings. Like if I would just call it my bad day, like I'm having a bad day, and that would be something on the spectrum of not being physically to get out of bed except maybe to pee, and not wanting to talk to anyone. And I'm usually a pretty like bubbly person. Like that's another thing with stereotypes, is like a lot of people with mental health think that people who are depressed are just these like really quiet, pale people who just sit in the corner and don't do anything. And I'm like, no, I'm like a super overactive, pretty bubbly human. And I have so much depression that paralyzes me in bed sometimes. Like people are like, no, that's not possible. I'm like, no, this is me telling you the truth. And so whatever your thought process about depressed people are, you got to like break that down, because we can't just put everybody in a box. It's really important. And so the sense of community, and nurses love community, man. Like remember a few years ago when they talked about the doctor talking about the stethoscope on
The View?
And it's like, on The View. Yeah. Suddenly there was like a nurses stethoscope Facebook group, 300,000 people large or whatever. Like people love community. Nurses love getting together. But mental health is not one of those pieces that we're really ready to get together on yet. And so hopefully we can change that.
Oh, goody. And then, so last question. Thank you so much, Sarah. Absolutely. Love it. Right. So last question. For all of those people listening, watching, understand, I started a new Facebook group, and it's called Nurses Are Human Too. And I love to remind human beings this, I love to remind nurses this, right? Nursing is your profession, and everyone says nursing isn't a job, isn't it a career, it's a lifestyle, you're a nurse 24/7. But remember, before you were a nurse, you were a human being. And I love to ask this to all of my guests, all of the people I have on the show. Outside of nursing, I don't want to know any of your nursing education, your nursing trips. I want to know just you, Sarah Wells, as a human being. What are the things that you like, that you enjoy, the TV shows, the trips, things that have nothing to do with healthcare, that you like, that you enjoy?
Yes. So I love traveling. I'm like that person that's like every which way, somewhere on a plane, somewhere all the time. And I love traveling with my friends. I love traveling with my husband. I love traveling with my family. Just going and seeing new places is like a big thing for me. And I love sports, and I love traveling for sports. So I played rugby in college. For 4 years, I was a badass, and then I retired at 22. Won't do it anymore because my back hurts. But I love watching rugby, so I've gone to multiple World Cup events, and it's a great way to see the world and travel and hang out with people who love the same thing that you do, but in like really foreign,
real quick.
places.
Were you at the World, I don't know if it's the World Cup or whatever, but I went to the one last year in San Francisco.
Oh yeah, the Sevens tournament. Yeah.
The Sevens. I was there.
Sevens is
fantastic.
amazing.
It was fantastic.
Amazing. Who were you supporting?
A lot more action.
So much more.
Yeah, than the regular 11 or 15. How many? It's 11?
15's full. Yeah,
15 is full. Yeah. I think there's a lot more action in 7 compared to the 15. But I was supporting. I know nothing about rugby. I was there with a friend that's from Kenya, and we were supporting.
Oh, the Kenyan team and their fans are the coolest.
Don't even get me started.
They go the farthest. Often it's like them and Fiji. So Fiji and Kenya have like a strong following. They show up in hordes, like millions of them, in like a place like San Francisco, which is not near Kenya or near Fiji. And they show up and they throw down and represent for their people. They are singing, they are chanting, they are laughing, they are dancing. They have the food out there. They're in like tiny outfits, no matter how cold it is in San Francisco. It is amazing. So good for you.
Yeah, no, I had a goddamn blast. I had an absolute blast. All right. Before you go, Sarah, just plug away. I know you just did it a little earlier, but I want to remind the people, listen, you guys, when I do these interviews, like you can obviously tell the ones that I get super into and that I want to ask a million questions to. And then you can obviously tell the ones that I have to do all the pulling. And Sarah, thank you so much for coming on, right? Thank you so much.
You're welcome. Thanks for reaching out. This was so great.
So please plug away, everyone. Please listen, take goddamn notes. It's going to be in the link down below. So listen up and go check her out.
Okay, so the website is like the key place to go. It's www.nurse.com. Email, very easy, newthingnurse@newthingnurse.com. And all my handles, the Instagram, Facebook, are @newthingnurse. I'm on LinkedIn. Please connect. I do a little bit of the Twitter, but not as much. I'm pretty big on the Instagram and Facebook. But please reach out anytime through the website, through email, through whatever. I love hearing from people that have heard me on podcasts or on like other media. If you're a nurse, if you're an aspiring nurse, if you thought about a nurse, if your sister's a nurse, your mom's a nurse, your daughter's a nurse, your best friend's a nurse, or your dog like wore a nursing outfit one time, I would love to connect, no matter where you are in the world. So that'd be really fun.
Oh, good. Sarah, before I let you go, everybody listen, y'all, you just heard our plug away, but remember, wherever you're listening to this, if it's YouTube or the podcast, like, subscribe, comment, review, let me know, all right? And then, so Sarah, thank you so much. Absolutely love it. Enjoy your trip.
Thank you. I will. And I'll reconnect and we'll talk about it. I would love that.
Yes. Please and thank you. Sarah, I got to bounce, but thank you.
Thanks.
Bye-bye.
Bye.